Hi, everybody. Good evening, and thanks for taking time out of your day to join us tonight. My name is Brenda Moynihan, and I'm the Director of Marketing and Outreach here at the Kensington Assisted Living Residence in White Plains, and I'm honored to welcome you to today's webinar. Tonight's presentation is What's New in Parkinson's Treatment, the Success of Focused Ultrasound to Treat Symptoms of Neurological Disorders. And before I introduce our speaker, I'd like to tell you that here at the Kensington, we have an informal Parkinson's program for our residents. It consists of staff specially trained in how to care for those with Parkinson's, special fitness equipment, and more. And we will be launching in early 2023 a formal Parkinson's program called Live Well with Parkinson's. And this program will include weekly offerings for residents as well as their families, dance and wellness programs, creative journal expressive arts, a support group for families, and much, much more. So please be on the lookout for more information about this program in early 2023. And as always, if you'd like information about the Kensington, please feel free to call us at 914-390-0080. And there'll be a Q&A at the end of the presentation, so please hold your questions until the end. I'd like you to join me in welcoming our speaker for this evening, Dr. Gordon Baltuch, and I'd like to read you his bio. Dr. Baltuch is the co-chief of the Division of Functional Neurosurgery at Columbia University Irving Medical Center. He is part of Columbia's team of experts in diagnosing and treating neurological diseases, including Parkinson's disease, essential tremor, and additional movement disorders. Dr. Baltuch was one of the first neurosurgeons in the US to use deep brain stimulation to reduce tremor and other motor symptoms in people with PD, and he is one of the most experienced neurosurgeons in functional neurosurgery. He also pioneered the use of the technology to treat epilepsy, depression, and Alzheimer's disease. More recently, Dr. Baltuch also became a pioneer in the use of focused ultrasound, and that's what we're going to talk about tonight, a non-surgical procedure approved in 2016 to treat essential tremor. Since 2017, he has successfully performed hundreds of these procedures and developed the University of Pennsylvania Perelman School of Medicine's focused ultrasound program into one of the largest practices in the country. Among other honors, Dr. Baltuch received the Wilder Penfield Award in Neurosurgery from the MNI, the K.G. Mackenzie Award for Basic Science Research from the Canadian Neurosurgical Society, and the Luigi Mastriani Clinical Innovator Award of Excellence from the Faculty of Medicine at Penn. Welcome, Dr. Baltuch. Come on down.
Thank you very much, Brenda, for this that very, very kind introduction, and thank you all for coming to listen to this presentation this evening. Is everything looking good from a technological point of view?
Looks great. I'm going to stop my video and mute myself so you can do your thing.
Terrific. Well, thanks for all for joining me this evening. I wanted to update you all on a really exciting technology that we've been using and discuss. Let's see if we can get this now. Okay, let's see, slide. There we go. Now it changed. And the learning objections this evening is how we can talk about treating two conditions, essential tremor and Parkinson's disease, using high frequency ultrasound. And let's start just discussing these two conditions, which are different, but have some relationship to each other, and then we'll get into the treatments. So the first condition to talk about is essential tremor. Essential tremor is a really, really common movement disorder. It affects actually 10 million people in this country, incredibly common. And the incidence of essential tremor increases with age, so that you can see on the population that's greater than 65, almost 5% or 1 in 20 people have essential tremor. It's a tremor that happens when you try to go and do something with your hand, use a spoon, a knife, try to write, sometimes try to dress, put on makeup. And so it's known as an intention tremor. It runs in families, though you can have it without having had a family member having it, but there is a genetic component to that. And that's why it also gets called familial tremor sometimes. As it progresses with time, it causes a lot of disability because you can do less and less things. And there's comorbid, there's depression and anxiety as you become sort of depressed because you're inhibited in many of the things that you can do. There's actually data that says that there's a given percentage, which is not insignificant, of people that decide to retire because of their tremor, which I think is really, really sad. In a more senior population, it can result in a huge loss of independence in the activities of daily living, as people have trouble feeding themselves, dressing, and the level of care can go up. So it is a real big cause of disability in our population. What kind of treatments are there for it? Well, essential tremor itself, there's no specific medication that was ever developed for essential tremor. What people have used in terms of drugs has been two main drugs. One is a beta blocker, which is a cardiac drug, which is a heart drug. And the other is primidone, which is actually an anticonvulsant, which is really primarily an anticonvulsant used for epilepsy. But people have used these medications for essential tremor. In over half the population, however, the medication does not work. And then a lot of people, for a variety of reasons, especially seniors, can't take these medications. Beta blockers, because they slow your heart, and that can be dangerous to a certain group of people. And the issue with primidone is it's a metabolite to a barbiturate, and it tends to be sedating. And the last thing people want, especially seniors, is to feel more sedated by a medication. So these medications tend often not to work. Sometimes they work a little bit at the beginning, but they tend not to work with time. So there's a huge need for therapies with essential tremor. Now, and the next thing we move is to talk about Parkinson's disease. Well, Parkinson's disease is a terrible disease. It's a progressive neurodegenerative disease. It affects at least 1.5 million people in this country, and it's associated with a high degree of functional disability. And it, some of the symptoms, they're motor and non-motor symptoms. The motor symptoms can include tremor, they include slowness, they can include stiffness, they can include walking difficulties with gait freezing, and the non-motor symptoms can include mood changes, cognition, in the end, swallowing problems. So this is a neurodegenerative progressive disease. Fortunately, with Parkinson's disease, we do have some fabulous medications that are first line, that have really revolutionized the treatment of Parkinson's disease and work very, very well for many people in the first sort of 5 years, often, of their treatment. One of the issues, however, is that over time, the medications sometimes not only don't work necessarily as well, but can be associated with side effects, i.e. abnormal movements known as dyskinesias, and also fluctuations, where you can go sort of on this roller coaster of symptoms where you go up and down and up and down. As well, there are a certain number of people who, no matter what medication they take, their Parkinson's tremor, which is a tremor which is a little bit different from the tremor of essential tremor, and that the Parkinson's disease tremor tends to be resting and more pin rolling, just doesn't really respond. Now, I'm a neurosurgeon, so when I see patients in the office, there tend to be patients who've been seen by very competent neurologists and doctors, and who feel that those patients are not getting adequate control with medical therapy of their tremor. And those are the people that we will see for evaluation for possible surgical options. Now, what are the surgical options that we have for movement disorder to treat primarily these tremors? Well, there are three of them. One is deep brain stimulation. One is focused ultrasound, and there's also gamma knife radiosurgery, which I'm not going to talk about as much this evening. Now, deep brain stimulation, we have been doing for a while. It started out in the late 80s, early 1990s. In Europe, we brought it to the United States to take care of people with both Parkinson's tremor as well as essential tremor. And over time, I've performed 1,600 deep brain stimulator cases in which we place wires deep in the brain, in structures in the brain. And here I'll show you a picture of what that looks like. Here you can see the deep brain stimulator through a nucleus. It's about the size of a Rice Krispie deep in the brain. And we have very modern technology now to do this and accurately and safely place these deep brain stimulator leads. But they're wires in the brain. They require incisions. They require burr holes to be made. And it's still a neurosurgical procedure, which is at least 6 to 8 hours. And requires an in-hospital stay. And we do these every week. I just finished an 8-hour procedure of deep brain stimulation today. Here at Columbia, it is something that we do, and for the right indications, it's an important part still of surgery for movement disorders in patients with both Parkinson's disease and essential tremor. Well, what about focused ultrasound? Focused ultrasound is a little bit newer. It was only really developed in the last sort of 10 years, although people have been working on the technology probably more than 20 years. And we've done, if you look worldwide, there have been about 250,000 cases of deep brain stimulation done. Here, you only have about 5,000 cases worldwide so far that have been done with focused ultrasound. It's been relatively new. We've done 300 cases compared to 1,600 DBS, but it's growing in popularity. Most of the cases we've done have been done for essential tremor, but we've also done them for Parkinson's tremor as well. Now, what is focused ultrasound? Let me see if I can get this slide to work. And what this is an incisionless procedure where you go into the MRI and we focus beams of sound, ultrasonic beams, and by focusing them, what we're able to do is create a small thermal lesion deep in your brain in the place where we would normally be putting the wire without making an incision. And we can use the MRI both to target where we want to steer this energy, and we also have a way here, and I'm showing with the cursor, a way of controlling what the temperature is, so we can and sort of crafting a three-dimensional thermal lesion in your brain in a very, very unique way. This is a procedure that you're wide awake for, and it's a 2 to 3 hour outpatient procedure, and it's got huge advantages to it. The effect is immediate, so you come in with your tremor and you leave without your tremor. There's no incision. There are no wires. There's no pacemaker. You don't need to come for a programming. Sorry about my spelling right there. Apology for that one. It's an outpatient procedure, and you go home in a few hours, and you can go back to where you're home and back to your activities the same day. There's no anesthesia necessary for this procedure either. So from those point of view, it's terrific. And especially in a group of people, and we'll talk about afterwards, this is a really, really nice alternative to what has been available previously. Now, what about, I mean, that's nice, but what about the, the data? Well, the data is, here's the original trial published in the prestigious New England Journal of Medicine, showing that in a randomized trial, this is what we know as class 1 evidence, that this really actually works. So this was done in a randomized fashion compared to a sham control, and it showed that you could really help people with essential tremor. And then this got published in New England Journal. Now, I would say probably about 8 or 9 years ago. And this sort of launched a group of centers to start doing this. And this was from a presentation from the CEO of the company, which has developed this device. And he showed here, if you look at DBS over the years, it's slowly going down. But look at the popularity of focused ultrasound as people really like the idea of an incisionless procedure that is an outpatient procedure with no wires and has a really nice safety profile. Well, let's talk about the safety profile because people are going to want to know, what are the risks? Is it safe? And what's the big risk? Well, the big risk profile of making this small thermal thalamic lesion is the risk on balance. And almost always your balance can get a little worse temporarily. In certain people, it's almost always temporary. There are some people, though, there is a risk of having some permanent balance issues with this procedure. Now, the people who I have asked, who I know, because we've treated 300, so there have been a few who have had some permanent balance problems. I've asked them, would you do this again? Would you do this procedure again, knowing that you had some balance issues? And they all say, absolutely. I can now use my hand, I can write, I can eat. I asked them, well, what about the balance? Well, they say, what can't you do? Well, one gentleman would say to me, I can't do social dancing anymore. But, I'm in my 80s. My wife passed 5 years ago. And I really am not doing social dancing anymore anyways. So, this is much more important to me that I could have tremor suppression and that I can go about with my activities of daily living, that I'm not embarrassed to go out into a dining room, into a restaurant, and hold a fork and spoon and hold a glass. So it's really, really terrific that way. What other risks are there? Other than balance, really, there are very, very few risks. I mean, you have to have this done by someone who is expert in it because the area is a very high-priced piece of real estate deep in the brain, and you have to craft this very carefully. One of the things about this procedure, which is often turns people off, is you need to get your head shaved at the moment for this procedure. Now, in a more senior, follicularly challenged man, that's not such a big deal. But in some, other people, getting your head shaved is a big deal. The reason behind it has to do with the sound waves. Is for some reason, the sound waves get caught up in the hair follicles and then they can't get into the brain. They tried with shower caps to get around that, to try to treat people with shower caps, but that didn't work. So the engineers still haven't figured out how to get around the head shaving, but they're working on it. And I keep telling them, people don't want to have their head shaved. Certain people try to do something that they don't need their head shaved. However, hair grows back and then you don't have the tremor anymore. So that's something to consider. And we have gotten people some nice wigs that they wear. And most people, in the end, it hasn't really bothered them. They're so happy to have their tremor suppressed. Does the effect last? Yes, it does. It's a newer procedure. So unlike, deep brain stimulation, where we have follow-ups of, 25 years, here we do know that the effect lasts. And you can see here, this is an article recently published showing that at 5 years, there's a really good, nice effect on it. So the effect really does last. Let's say it only lasts for a while and then the tremor came back. Could you be retreated? Yes, you can. And actually, I've retreated a few patients. We had one patient who's a physician and internist from central New Jersey. We treated him. He did really well, but after 2 months, he called me. He said, you know what? The tremor came back. Could you try again? we did the procedure again, and now he's been like 6 months doing fabulously with no tremor. Another question that comes up is, can you treat both hands? At the moment, unfortunately not. You can only treat a unilateral hand, so just one hand. Usually it's the dominant hand that gets treated. We've done a trial that's completed doing the other side. So someone, let's say, had one side done, and then 6 to 9 months later, we do the other side. And we're at the FDA now, hoping to get, and we think we will get approval so you could do both sides. Now, would you do them all at once? No, you'd have to have one side done at one point, and then you'd have to wait probably 6 to 9 months to get the other side. But what we are seeing when we treat both sides is not only that people have reduced tremor in both sides, but the functional improvement in their life quality seems to be improving with both sides treated. So that's really interesting. That'll be the next time I talk. Hopefully I'll have more news on that. This was the long-term stuff. How about some interesting cases? Well, you know, here's a gentleman, 93 years, young at heart, with tremor. And this is, you look at the brain as a neurosurgeon, this is not somebody who, you would want to necessarily, make an incision in, make a burr hole. Yes, we could do it, but the risk is pretty high. And here you have someone coming with a tremor who gets treated, and you can do a really nice incisionless focused ultrasound thalamotomy and really get excellent tremor suppression, an outpatient procedure. They come in the hospital and they leave the hospital. Fabulous. And we've treated people now, I think, up to the mid-90s. I think the oldest person who's been treated, I think, is 97 or 98 years of age with this procedure. So this is really a terrific procedure for seniors, especially, with comorbidities, et cetera, that accumulate. This is a great procedure for someone who wouldn't be a candidate for something, a major neurosurgical or getting general anesthetic. This is another interesting case that we did. This was an unfortunate gentleman who he had a small cyst removed from deep in his brain, which was causing him problems. And this was done somewhere else. And as a result of that procedure, he suffered a stroke. Subsequent to that, he wound up having a seizure disorder. Subsequent to his seizure disorder, he fell and he had subdural hematoma, which needed to be evacuated. I mean, the story goes on, the saga goes on, but he also wound up having essential tremor. And here you can see he's had major craniotomy and major brain surgery. He's had burr holes for subdural. And this was a case that we published that, this is not someone you're going to want to go in and put wires in their brain. They've just had enough done. Look at all this stuff. But he's a great candidate. We did focused ultrasound. We're able to, eliminate his tremor, and he did fabulously well. Really, really nice indication for this. Now, I'm back here talking about the bilaterals. We spoke about this already. We're in FDA review, and they've already done them in Europe as well and published them because they sometimes are a little bit ahead with some of that stuff because of regulatory issues, showing some really, really excellent results with the bilateral procedure. Now, we've been talking about treating PD tremor and essential tremor with this procedure. But what about the other motor symptoms of Parkinson's disease? What about the slowness, the stiffness, the abnormal movements of PD? And we have started and have approval. We started treating and doing unilateral pallidotomies in patients who had bradykinetic Parkinson's disease, who had slowness, stiffness, dyskinesias. A lot of people have problems with dyskinesias, and we had FDA approval. And we've treated, we did the trial. We've been treating patients with this successfully. These are people who either would not want to have wires placed in their brain, are not candidates to have wires placed in the brain. We have people coming from really all over the world for this procedure because they do not want wires placed in the brain. Sometimes I will, I'll meet them, I'll give them options. I would say, I think, you would be better off with wires in your brain. They say, doctor, thank you. That's not what I want. I want something with ultrasound. I don't want an incision. I don't want wires in my brain. This is the procedure that I would like. And it's really exciting. And this hopefully is going to be, hopefully is going to get published fairly soon, also in a very good journal. Now, to finish up, I just wanted to talk about some of the future challenges and that we can do with ultrasound. And one of the big challenges in treating people with Parkinson's disease over the last career of mine, which is now 30 years in this space, has been progression of disease. That in spite of everything we do, the Parkinson's progresses, even though we help the motor symptoms. There is progression, and in the end stages, unfortunately, there's cognitive decline, which is really, really challenging. And my hope is that we could find something that could prevent this progression of disease and the cognitive decline. And when we look to that, what we're looking for is restorative therapies, like to restore the loss of that's been in the brain with something that we can put back into the brain that could help either restore function or prevent progression or cell loss. And when we look at some of these now, how do we put things in the brain? Well, at the moment, one of the techniques that we've been using, and this was from a recent trial, is we do these very slow injections in an MR machine, connecting these to a tracer, which is so we can see as we inject into the brain. I'll show you this stuff here and there. These are long operations. They take 10 to 12 hours. This is highly investigational stuff, but this is the best that was sort of state of the art, the best of what we have. Now, could we use ultrasound to get these agents, whether they be genes or cells or enzymes, into the brain? And the answer is yes. And this is some of the groundbreaking work that has been being done at Columbia in the engineering department. And what you can do is here, instead of using ultrasound to make a small lesion, what you can do is you can actually use it at a sort of a lower energy, and you can open up something known as the blood-brain barrier, and with these little bubbles, and then you could actually inject here your agent, not only microbubbles, but your agent as well. It would cross in a specific place, get into the brain, and you would get your agent in that way. Now, has it been done? Absolutely. Just recently in Toronto, one of the pioneering groups was able to deliver a glucose cerebrosidase into exactly the spot that I was showing you before, that we were using that in convection enhanced thing. And in a few patients, they were able to show that they were able to do this for patients with Parkinson's disease. This is really, really exciting stuff. And I'm hoping in the future, we're going to be able to bring this on, and this will be, there are a lot of really, really exciting agents people have, genes and cells and enzymes that they think that could really help people with Parkinson's disease. The question's always been, how do you deliver the agents? How do you get them into the brain selectively? My hope is that through this investigational method of BBB, or blood-brain barrier disruption, we're able to do that. I mean, stay tuned. I mean, this is very highly investigationally exciting stuff, but this is what the hope is for the future. I'm just going to finish off by saying, it takes a team, it takes a village, no man alone. The team we have at Columbia New York Presbyterian is, second to none. It's just a fabulous group of people who come together to try and help patients and do the best. And I'm really, really fortunate to work with this terrific group of people. And of course, a special shout out to Hanan Shebanu, who's come up to from Philadelphia to work with me, who's the APP. She's a DNP and nurse practitioner, and it's just been a phenomenal team. And also special shout out on the picture here to Maria Alba, who's the coordinator, who's also come on in a really tough time and has done a fabulous job. And I think I'm going to end right there, and I'm going to open up the floor. I think I've spoken enough. We're going to open up the floor to some questions. Thank you.
Absolutely phenomenal information. This is really, to me, cutting edge. And we want to open it up, so folks, please type in your questions. As you're typing, I have a few questions of my own. The first is, can you have essential tremor without having a Parkinson's diagnosis?
Yeah, so they're different. So they're both different diagnoses. There is a mix, but they're sort of different. They're different states. Essential tremor is not Parkinson's disease. Essential tremor is a tremor that you have when you try to do things. Parkinson's disease is a neurodegenerative disease, which can be associated with tremor, but you could have Parkinson's with no tremor at all. You could just have slowness and stiffness. So they are separate. There are a small subset of people who start out with essential tremor and then go on to develop Parkinson's disease. It's probably like about 10%. Now, sometimes they're hard to distinguish the two. You can do a test known as a DAT or a DAT scan, which will tell you whether you have Parkinson's disease or not. But it's a great question, Brenda, because we see lots of patients in the office who have had confused diagnosis, either one or the other.
Okay. Is there any pain with the procedure?
So there can be, when can be a sensation of heat when the sonication is done. And as the energy can go up, sometimes it can be slightly painful, but we have anesthesia on board. We don't give strong drugs, but we can give things like IV Tylenol to help with that sensation. But for the most part, it's not a very painful procedure.
And this was one of my questions, but I see we have someone who also is asking, is it covered under medical insurance?
Yes, it is definitely covered. We work very, very hard to get coverage, and we have coverage.
Right. Can you use the procedure on someone who has had deep brain stimulation?
Unfortunately, if the wires are still in place and you have a deep brain stimulator in place, at the moment we cannot do it because the sound waves can bounce off the wires. Eventually, we'd like to maybe try to figure out a way that we could get around that. But at the moment, with the wires in place, we can't. Now, if you had the wires in place and they didn't work and they took the wires out, or let's say you had an infection, then you could go back and do this procedure. So we've had a few patients who had infections. The wires came out, and then we did this procedure successfully.
Okay. Who would not be a good candidate for this?
Okay, so who is not a good candidate for this procedure would be someone who, let's say, they're actually if you are on a blood thinner, right? And you can't come off your blood thinner, you need to stay on your blood thinner. At the moment, you need to come off a blood thinner to get this procedure. So I didn't talk about Gamma Knife, but if you can't come off your blood thinner, you can get Gamma Knife. If you have like a certain kind of pacemaker, then you can't get into this machine at the moment with a certain kind of pacemaker, because it's done in a certain type of MR machine. Some types of pacemakers you can get into the machine, sometimes you can't. So those are people who you would be concerned would not be great candidates for that. Other than that, for the most part, most people are really good candidates for this procedure. There are a certain group, we have to do a CT scan on all the candidates to make sure that their skull thickness is the right skull thickness for the procedure. There's about 1 out of 20 to 1 out of 10 people who have a ratio of soft to hard bone where the sound waves can't get through. It's a weird type of thing, and the engineers are working on solving it, but it's not completely solved yet.
Wow. So we have someone who's asking a question. Can this be a procedure used on someone with Parkinson's with Lewy body dementia?
Potentially. So the data is looking like that it doesn't impact cognition. So it's not going to make your cognition worse. So then you'd have to ask, well, if you had Parkinson's with Lewy body dementia, what would be the goals? Because we've treated some patients who had PD who were not cognitively well at all. And if you have someone with PD who has, let's say, is in an assisted living facility or at home and has severe PD tremor, so that their caregivers are having to feed them, they can't feed themselves, but have a lot of cognitive decline, you could, and we have treated their tremor so that we improve their quality of life and the quality of their caregivers' lives, without impacting negatively on already a very decreased cognitive reserve. I would be concerned about treating other motor symptoms of someone who had PD with severe cognitive decline. I think I would be more likely to want to treat someone who had severe cognitive decline or dementia if it was really tremor, and this was for the basic activities of daily living in a situation, and really to help the caregivers and the level of care.
How many facilities in the country conduct this ultrasound work? Also, can a newly diagnosed PD patient receive treatment?
So I don't know exactly how many. I know they've become much more popular than there used to be. I would say, I'm going to say somewhere between 10 and 100 exist. There are only 2 or 3 in the area here, the New York area. So there are not a lot of machines. I think there's a huge back order because this procedure has become very popular.
Sure.
The procedure, they're made in Israel. And I think it's like 2 or 3 years to get a new machine if you ordered one. So they're not a lot, and they take a certain amount of maintenance. Now, if you're newly diagnosed with Parkinson's disease, go back to the first slide, you should not be getting a surgical procedure, right? Parkinson's disease, in my mind, can be treated via a variety of non-surgical means. And it's I'm not a neurologist, it's way beyond the scope as to when you start medication, when you don't want to start medication. But I would be concerned about just starting with a surgical procedure. I've heard that some people have pushed to do that in Europe, but I would be very, very apprehensive. Usually the people that we see with PD have had PD at least 5 years. Now, if you have PD and you have terrible tremor, and no matter what medication you take, you still have tremor, or no matter what the medication makes you very sick when you take it, then you could be a candidate. But I think you'd have to try that first.
Okay. We have a question. I'm not sure I understand. Do the wires stay in? Mel, I'm not sure if you're referring to the focused ultrasound or the deep brain stimulation.
Okay, so deep brain stimulation is the wires are in. You implant the wires, you're, as they say, rewired for life. You've got wires deep in your brain and they hook up to a pacemaker and it sends electricity into your brain continuously. So then you have wires in your brain. With focused ultrasound, there are no wires. There's no incision. You know what I mean? There's no incision, no wires at all. You come in and you leave.
We have a question. I'm a bit confused about what you discussed at the end. Are you saying that the new ultrasound being tested can help with the progression of Parkinson's?
What we're hoping is that the new ultrasound being tested is going to offer a better delivery of agents that we are hoping are able to stop the progression of Parkinson's disease. And I said that it's highly investigational. We don't have anything that stops the progression yet, but the hope is that this would be a way that we could deliver agents which might have the potential to stop future cell death. I mean, that's the dream. That's the holy grail. We don't have it. We're dreaming of that. But now we've shown that at least we can get, in Canada and Toronto, they showed that they could get the substance in with this form of focused ultrasound. And that's what's really, really exciting, as opposed to previously when you've had these operations that take 10 to 14 hours.
What if you have hardware in your neck as a result of cervical spine injury? Are you still a candidate for this procedure?
Yes, you are.
Okay. My husband, age 81 with PD, has very little tremor, but severe rigidity, stiffness, freezing, poor balance, and also trouble speaking, stuttering, and aphasia. Would FUS help in any way?
It's a tough question. It's possible that it might be able to help, but that would be those are, we take cases like that and we look at them in a multidisciplinary fashion among a group of neurologists, and we do sort of an in-depth look at someone and the videos. Those are complex cases. They're not an easy answer. So I know you're looking for an easy answer, but that's a case that you could say maybe, but that would definitely be the case that you'd want to really, really discuss in a conference, in a multidisciplinary conference, and really hash it out and go over the pluses and negatives before you made any decision.
Okay. If a person with PD is on medication to control tremor, have those treated been able to come off on all of their medications?
No, PD is a brain disease, right? And when you get focused ultrasound, it's unilateral, so you're going to still need the medication for the other side. However, deep brain stimulation, right? We do have patients who had tremor who we treated with bilateral deep brain stimulation, which is approved, who wound up coming off all their medication. So you can do that with deep brain stimulation, but that's a bigger operation with more risk. So, again, you're looking at a balance of safety and efficacy, so I'm not sure in that case, we can give you with focused ultrasound yet the efficacy that we could with deep brain stimulation. Maybe one day, but not today.
I think this question refers to what you were saying at the end. They're asking, what kind of agents are they? Are they drugs?
Oh, so the investigational agents, there are a variety of things. Some of them are genes, right? So gene therapy. Some of them may be enzymes that you're putting in. So those are the type of things that you're looking to put in. Maybe one day cells. So those are the real agents. So you're trying to little factories that produce substances in the brain that are neuroprotective or restore chemicals that have been lost. So that's what you're looking for.
So Dr. Baltuch, I have a question myself. The focused ultrasound, you said, are sound waves, and you're pinpointing an area in the brain. As you're going through the brain, how does it not destroy the other parts of the brain as it's going through?
Well, what it is it's, if you imagine like when you have a magnifying glass, right? When you're a kid and you take a magnifying glass and you burn a little hole in a piece of paper, and that's exactly what you have. You've got like 1,000 sound waves. Each sound wave in itself is very weak, right? But when it coalesces in one point, then it can create a thermal lesion, just like those light waves, right? When they all coalesce on the piece of paper with the magnifying glass, you could burn that little hole. So that's why they don't hurt the brain at all, really, on the outside. It's just at that point.
Okay. And we do have time for one more question. Do you have any estimated time frame for the development of the new focused ultrasound that might address PD progression?
Oh, I wish I could answer that. I wish I could,
question.
I wish I could answer that question. I hope it's sooner, I hope it's sooner than later. And my real hope is that before I wind up leaving the party, that we have something to take care of progression. That's my dream, you know, that really is my dream.
Right, right. Well, folks, I want to thank you all for joining us this evening. Dr. Baltuch, that was fantastic, great information. Folks, please stay with us until the very end. We're going to put up a slide that will include Dr. Baltuch's information if you'd like to contact him. Also, the Kensington, you know, we're here for you. Again, we have a Parkinson's program. If you'd like to contact us, please call us 914-390-0080. This presentation was recorded, so it will be posted on our website, also Facebook, if you'd like to take a look at those slides again. And also probably by Monday or Tuesday, I'll send an email out to everyone, again, with Dr. Baltuch's information. Please, I encourage you all to contact him. So thank you all for coming. I'd also like to thank my colleague, Gina. Gina is on the back end, running the back end of our presentations. So thank you all. Thank you, Dr. Baltuch. Have a wonderful
Thank you very
evening,
much.
folks.
Thank you, everyone, for coming tonight.